I've been with the Kidney Foundation for almost 14 years.
It'll take forever.
Almost forever. But it's not my first and only job, nor my second and only job. So I've had a few other things under my belt. But I joined the foundation in June of 1997, and I work technically, officially for the national office. Our headquarters is in New York City. We opened the government relations office in 1997, and I started working for them the day they opened. So been there a long time. Most of my focus is on congressional activities, and also a lot of things like this, and working with a lot of other similar organizations on a day in and day out basis. In fact, a lot of our state staff, and we have offices in probably about 35 states. We have about 40 or so local offices. In some states there's more than one, but generally we have about 40 local offices. And those people think I'm on Capitol Hill every day. Nothing could be further from the truth. I'm lucky if I get there once a week. A lot of what I do is this kind of stuff, meetings with other similar organizations, whether it's a dialysis focus or a transplant focus or a donation focus, or there's plenty of opportunities to do things in a broader healthcare sense. And I'm very good at telling people no, as far as can you join this coalition, or can you come to this event, et cetera, et cetera. Usually, if it doesn't have a specific kidney focus, I just have to decline, because I'm the only person in our office, and it's I can't be everywhere at once. But otherwise, and the meetings I do are a legislative angle, and I do the legislation. We do a lot of regulatory issues with Medicare and the other federal health agencies, but that's handled primarily out of our headquarters.
Did your father retire?
Pardon me?
Are you still a partnership, or did your father retire?
I know.
Is he still around?
My father?
No.
No.
What about your partner in NKF?
Oh, okay. Well, my big partner is able to be golf.
Yeah.
Yeah, he's still around.
Oh, yeah.
Yeah, and he does. He is I guess the main coordinator of our agency work. But we probably have about, I don't know, I would say 6 or 8 people, that do some piece of the agency stuff. By and large, that's Medicare, because the thing with the Kidney Foundation is the Medicare, the primary payer for dialysis for almost every American. That's obviously our overriding interest. Now, the one thing I always tell people about NKF too is I think we're unique in that we have an interest in virtually every federal health agency, certainly with every aspect of chronic kidney disease. If you look at something like the Renal Physicians Association, they're the trade association, or I should say that, the professional medical society. The practitioners are the people, the nephrologists who provide the care. Their main concerns are Medicare issues. Look at something like the American Society of Nephrology. Some of them are practitioners, but by and large, they're people who do research. So their main interest is national institutes of health. With us, we've got Medicare, we've got the health resources and services that Charlie talked about because of all the organ donation issues. We have things with CDC, FDA, etc. I'm not going to go into a lot, but I just want to kind of use this as a preview to show you what can be done. These are things that MKF and other members of the transplant community have been able to accomplish in the last, these go back probably about 6 or 7 years. The National Living Donor Assistance Program was authorized by Congress in 2004 under the reauthorization of NODA. And then it was up and running, probably more than about 4 years ago. That's a grant program whereby social workers can apply for financial assistance for living donors. And it's a federal grant program, and donors can get assistance for their out-of-pocket expenses to help them donate, and help kind of level the playing field, so to speak, of people who are able to donate who otherwise might have financial barriers.
Troy, just out of curiosity, we've heard some of these programs come up, and they get passed.
Yeah.
They don't get funded. How did something like that get passed and funded so that actually money
Well,
flows to the program?
the community had to go back to Congress and make sure that there was funding. Now, the donor assistance program is funded under, there's a single, what they call line item appropriation. There's a single account under HRSA that says in the annual appropriations bill for the Department of Health and Human Services says organ donation and transplantation, and it's about $24 to $26 million a year. The high water mark was like 26 something. I think right now it's about $24.5 million. So that it comes from that, but within that, we had to urge Congress to put in some language to the agency saying, X amount, or at least work with the agency to make sure it was funded. And that's a very good point because, getting the program created, sometimes that's the easy step. And then the hard part is making sure it gets funded, making sure it gets implemented. Even something like that, they go through a rulemaking process where they had to, set the criteria because Congress wasn't going to get specific as far as who could benefit. In terms of, for example, the priority is for, it goes up to 300% of income. But there's, I'm sorry, 300% of federal poverty level is sort of the cutoff. But if you make less than that, then you have a higher priority. There's also different priorities for the recipient, the donor, etc. So, you're probably familiar with the paired kidney donations, where you have more than one person donate, and usually it's a spouse or a family member or something where they're medically incompatible, so they can't, the one can't donate to the other. But the paired kidney thing is something that Congress, I guess you could say, authorized. I mean, it was. We always felt, and a lot of people felt that it did not violate the National Organ and Transplant Act, but there was some concern from the government that it might. So we had to go to Congress to get legislation to simply clarify that it didn't violate NOTA. And as kind of an example of how long it takes to get anything done, it was introduced at the beginning of a 2-year Congress, and we thought it would take like 6 to 10 months to do. It took almost 2 full years. And everybody thought it was going to be easy. And we had to jump through some hoops to do it, but at the same time, since it has been clarified and made clear that it doesn't violate NOTA, it's really taken off. I mean, you see things in the news now where there's, I don't know, I think they've done as many as 16, 18, 20 transplants at a time. Yeah. In fact, some in this area. I know they've done it at Northwestern Hospital in Chicago. Georgetown here has done some, Johns Hopkins, but I know all of those have done easily in double digits, 10, 12, 15 transplants at a time. That's probably not typical, but even doing 4 or 6 can make a big difference. A lot of states have income tax deductions and credits to assist donors with their unpaid expenses. And the last thing I put on is something that NCAP worked on for a long time. We call it the Medicare Pre-Dialysis Education Benefit. What that does is for kidney patients who are in stage 4 of kidney failure, so they're probably a year and a half away from needing renal replacement therapy, there's a new Medicare benefit that they could take classes, education things, sort of a setting like this, where they might go in a group of 10, 15, 20, 30 people and learn about the different replacement therapies. Because we were finding that all too frequently, people only really heard or understood in-center hemodialysis. They didn't always understand what the home therapy might entail. They didn't fully understand what it took to get on the wait list, what it took to look for a living donor. So that benefit basically pays providers a small amount, not very much per person, but it's an incentive for them to do these courses and give people a little bit of information up front about what they can expect. So, next slide. But very quickly, I just want to say it's going to be a really tough year. Everything, all the budget fighting you heard about in the news 6 or 8 weeks ago, that was all for fiscal 2011, which ends on September 30th. The upcoming year that they're already working on is going to be even more difficult, and it's everybody is pretty much on board with the deficit reduction now. I mean, there are some members of the more liberal wing of the Democratic Party that's not engaged in it, or trying to minimize the cuts that are coming. But by and large, even the mainstream Democrats are jumping on board with this, especially in the Senate. So we're going to see a lot of really needing to do hard work to justify continuing programs where they are. And just a few days ago, the Republicans are starting the appropriations process. These are the bills that require annual funding. So for HHS, it's basically anything other than Medicare and Medicaid, because all of the other health and human services programs require annual funding. But a few days ago, they started their allocation process where basically they get a set amount of money for the 13 appropriations bills they have to do. And for the largest one outside of the Department of Defense, largest by far, it covers the Departments of Labor, HHS, and Education. And you can see they're slated for about an $18 billion cut over what they got for 2011. That's about half of all cuts. The overall cuts are about $31 billion. So over half of that is coming from that one agency. And that revenue, those three agencies. And that's about 11% less than what they got for this year. Now, I don't think it'll really impact organ donation much at all, because organ donation is so small. The program under HHS, as I said, it's about $25 million a year, and the overall bill, funding bill for HHS is about $70 billion. So it might be tweaked a little, but on the other hand, it would be very hard to get an increase. In certain years, we've had like $1 million or $1.5 million increase in the organ donation program. I think that'll be a bit more challenging to do this year, unless you find a few champions. And that's where people like yourself come in, where you can develop some relationships with key people in Congress to help boost the visibility. Somebody mentioned immunosuppressive drugs. That's it's a favorite topic for NKF. If you don't know, the Medicare coverage for this ends, if you're not aged or disabled, you get a kidney transplant, all of your Medicare ends 3 years after the transplant. What we've been trying to do for 14 or more years is eliminate that 36-month requirement or limit, but only for the immunosuppressive drugs. We got very close last year. In fact, in the lame duck Congress after the election, so in November and December of last year, we had agreement from both Republicans and Democrats on this issue, House and Senate, to try to do a short-term extension. They were looking at the possibility of 3 additional years, just to get everybody to 2014 when the Health Reform Act insurance exchanges kick in. And it was something we proposed. We knew we didn't have a chance to really get the lifetime coverage we wanted, but we said, what if we just do short-term, sort of a bridge until we get to 2014. Unfortunately, they didn't get the cost estimate back in time from the Congressional Budget Office to move forward on it. But we had been assured by Senator Durbin from Illinois that he wants to reintroduce the bill. I had a conversation with his office about 3 weeks ago. And then a week ago, we got word from Congressman Burgess of Texas that he wants to introduce the bill. He's going to take it over from last year's sponsor, who was Dave Camp. And Camp is now the chairman of the Ways and Means Committee, which has jurisdiction over it, so it wouldn't be very appropriate for him to put a bill through his own committee. So Burgess wants to do it, and the interesting thing there is he's an MD, so it's an issue he's interested in. And also, Burgess's health staffer was working for another member of Congress a few years ago who helped us with the parent donation bill. So there's a good interest. Federal tax credit for living donors is similar to the ones that are at the state level. That's something we'd like to see happen, but I don't see it on the horizon right now. And boom, now we come to what you can really do. I know Charlie, he touched on a little bit about this, but I think these are all things you can do. I think the thing to remember is you've talked to a lot of people about what you've been through, and whether it's as a recipient, a family member, some other connection to the donation process. I mean, how many people have you told your story to?
Yeah.
A lot. Whether it's to people in your community, people in your workplace, strangers you meet on an airplane, whatever, family reunions, et cetera, et cetera, et cetera. So you know your story better than and the issues and the needs better than virtually anybody. I mean, the only person who knows it as well as you would be your medical team, and the Lori Brighams and Charlie Alexanders of the world. So you know what's needed, and you've told your story and your life lessons and your experiences to those groups I just mentioned. To me, it's not any different telling it to congressional staff and to members of Congress and state legislators about these are the issues, these are the needs. And I think there's definitely a large learning curve. I was actually thinking towards the end of the Q&A that we were doing with Charlie, I bet nobody knows that the general public has no idea there's 100-some thousand people on the wait list. And I bet most of them don't even know there's an organ shortage. Do you think?
Today...
I mean, do you think... I bet a lot of...
Well, let's put it this way. The focus of the OPOs in Running Life America has switched from awareness, because the studies now show that most people are aware, to action. So they've changed the whole process to get people to sign up for registry because the awareness is so high now. So it might transition.
But I wonder if they know how bad it is, or or if a wait list could be 7 years in some areas. I mean, I think people, they certainly know the need for organ donors, but I suspect they probably don't. The general public probably doesn't recognize, the extent of the need. And so I think a lot of it is just, getting the word out there and educating. So, these are things I think you do. I mean, you heard Charlie say you need to come to our, to Baltimore, we can host you. I mean, and there's a lot of different, organizations out there. Some of you probably have things, through your local transplant center and OPOs. I mean, I know that transplant centers sometimes do annual picnics and annual get-togethers for the recipients. That's an opportunity to find other people who have the common interest in going to the legislators and trying to educate about these are our needs. I'm sure the transplant centers would help with a similar thing.
One of our sessions later on we'll be talking about the challenges of the chapter, and one of the challenges are the recruitment of people to get involved in these organizations. And I think something's changed in our society over the past decade. I don't know if they agree, but I can take, for example, a heart support group up in the Philadelphia area, which is very strong, has 5 chapters, one with each of the heart transplant centers. With one center, as an example, I'm going to get right down to real numbers. Transplant last year, 61 hearts. Okay. Out of that, with an active group, support group there in that hospital, we got 1 member who joined the group. I mean, that's less than 1%.
And those are people who have the direct interest.
Exactly. I mean, they're right there. They understand, and they look like they need support. They want support, but they never come out. Our chapters, in general, are facing the same type of challenge. Aging membership, no new members coming in overall, even though more and more people are getting transplanted. It's more knowledgeable in the community. And I don't think it's apathy, but I don't know what it is. And so...
Well, I think it's because it's getting so common, transplant, that they feel like they don't need support.
But don't they go away with the sense that we all got involved with, like, hey, somebody gifted me, I have life now, reaching back, paying back the next wave coming through?
I think a lot of it is easier access to these groups online now. They on phones and get in chat rooms and discuss things with people all over the world. But definitely not within the area.
It's going to be interesting if our virtual chapter, which is using that technology, will take off or not versus the local geographic chapter where you got to go out at night, go someplace to meet people. It'll be interesting.
And you might attract people. People might want to get involved not only to help make a difference, but they might want to get involved as a way to find people with that common experience. And maybe on the web-based things in the chat rooms, they're finding that comfort zone with the people in the experience. So then that sort of takes away the need to go. I'm going to go be an activist. Does that make sense?
No, the guy in Arizona, Bob Arrington, he's right at 1,000 people joined up to his cause just in the last couple of months over the internet.
This first bullet, I mean, I think we run into people on Capitol Hill where they've got a specific interest in it, whether it's a staff person or a legislator. We just met a staff person a few weeks ago that we were introducing ourselves to in a new office, and they told us, that their grandmother's been on dialysis, very recently. So there's a lot of, there's definitely members of Congress, elected officials who have a spouse or a sibling that's, on dialysis or that's, had a liver transplant, heart transplant, et cetera. There's members who have had transplants. That's rare, but I mean, there have been some members of Congress who have had organ transplants. So there's, it's just a matter of finding out who they are. And I'm not saying, clearly that's not the only people you target, but my point is, pardon me?
They're the easy.
Well, they're the easy ones, but my point is, they're just like you. There are people, just like that. I mean, I go to a church with about, maybe 60 members there on 60 attendees on a regular basis. There's one guy who's a few years younger than I am. He's about 43 or so. His cousin got a kidney transplant a year ago. There's another person, she's about my age, and she has a coworker who is lining up to get a kidney transplant. So there's two people out of 60 or 70 of us who have a direct connection to the transplant issue. So I mean, I don't think it would be any different, on Capitol Hill, finding those kind of things. I mean, we know some of the people who have that interest, but
You're generating some thinking on behalf of all of us that we have liaisons appointed to NCAF, for example. In fact, I did call on the person because Captain Baker was there at the time, but we haven't updated that in a while. Partnering with you specifically to identify these people so that we could go after them in the sense of opening up a dialogue with them. I don't think the average Trio chapter knows who some of these people are, even in their own district. And so if we could partner with you to say, hey, we got a chapter here wants to do this, is there anybody that you can identify?
Yeah.
The other question I would have for you, Troy, and if it's later in the slides, I'll say it later. Going into Washington to meet with congressional leaders, I mean, typically you're going to meet with one of their office staff, a young intern who's getting their feet wet there. What impact, if any, does somebody with the passion we've got, who gets access to that person? I mean, you had a number of years ago, and I'm sure you've done it since, brought cadres of people from all around the country, great training of what to do up in the Hill. Hey, here's the message, here's your 3 words, here's where your story fits. It was so pointed, it was great. And so you got to meet the staffer.
Right.
This young guy, just out of college, he got a job in Washington. And he had all the same training on his side. Here's how you greet them, here's how you smile for them, make them feel good going home. And what impact does that have today?
I'll talk about the first part. I'm not gonna get on how they train there on their end.
Okay.
But I can talk a little bit about later.
Does it have an impact is what I'm looking for?
Yeah.
But what's that intern do
Right.
with the fact he was just touched by Jamie's story when she sat in front of him?
We've done the last 2 patient fly-ins we've done. We did the last in March for World Kidney Day. We brought in just people from the local area. We did DC, Virginia, and Maryland. But then, so those were all kidney patients in one form or another, whether they were dialysis, transplant recipient, a family member, et cetera. And then in September of last year, we had about 10 or 12 home dialysis patients come in from across the country. And those were our 2 most recent patient advocacy fly-ins, and smaller than what we normally do. We always do, typically with the one we do in March for World Kidney Day, we have about 25 people. This year was smaller, but generally the other ones we do are 10 to 15. And at both of those, the staff were I think more so than ever, really interested in hearing the story, which I'll actually get to that a little bit more later. So the next slide. So, I kind of talked about this already. I mean, you know it. You know the impact on yourself, what it was like to be on the wait list, what it was like to find a donor, whether it's a living donor or a deceased donor, what it means for your family, not only when you were ill, but I'm sure there's impacts on the family as a recipient. You've been through it, so you can tell, the story to your legislators about the disease. I think that's probably the easy part for you. And then you can, and on top of that, you can also talk about, here's what it meant to be on the wait list. Here's how long I waited. Here's how fortunate I was. There's other people, behind me that haven't been transplanted yet. There's people behind me that, that passed away before they could get transplanted. I think you're able to relay the message to them on the needs, and the needs are things that would be identified by your board, your legislative and policy priorities. A lot of them are common. The transplant groups work on them together. I mean, there's a little informal group in DC called the Transplant Roundtable that TRIO participates in. It's all of the transplant patient groups, the transplant medical societies, some of the other professional groups. It's probably it's not just solid organs; it's also the ion tissue. AOPO has people, a representative come there. UNOS does. There's probably, I guess, about 20 members, and we meet about 4 times a year and talk about common interests. And invariably, there's probably 4 to 6 legislative initiatives or agency policy initiatives that we work on together throughout the year. So, this is when I said legislators want to hear about people so they're real people now more than ever. I think I mean that's what I've experienced. Not only in the last couple times we've had the patients go up to the Hill, but even in our everyday visits to Capitol Hill, I think they're increasingly sensitive to the voters and the voter dissatisfaction, and I think large part of that's the pendulum's been swinging. I mean, you think about 2.5 years ago when President Obama was elected, and even the 2 years before that when a lot of Democrats were elected to the House as freshmen. 2.5 years ago, all the pundits thought, no, the Republican Party is going to be in the minority for the foreseeable future. Then you had last November where 80-some Republicans come in office, and the independent voters are very fickle, and they want results, and they want results now, and even if they don't want to put the blame at somebody's feet, that doesn't mean they're not going to vote for change just to say, all right, we need another change. So I think Congress understands that, and I think they know that their shelf life is very, very short, and they want to please, I think, more now than ever. And always, when they ask members of Congress and staff in any kind of polling or questioning, what influence the constituent input and visits? You look skeptical.
I do, because I mean, you're a politician. So you said, are you influenced when your voters come in? Yes.
Yeah.
I mean, are they really?
Yeah, but I think they are.
Yeah?
Yeah. Because, like Charlie said, I mean, he said that you can tell your story with more passion and more convincing argument than he could, and certainly more than I could. So these are just you were asking just Jim, simple things. These are very simple steps, and that I don't think it's any different what you would do meeting with a state official or a federal elected official. Just be ready, be organized. I mean, know what you want to ask. Don't have overwhelming material. Have some simple things with a simple ask. I think the main thing you want to do, at least the first time that you introduce yourself to them, is kind of tell your story about why you're there and some simple needs. The other thing is, I think it's on the next slide, be persistent and available. I mean, we've got volunteers that know the state staff of their representatives and senators very, very well. You know, they've developed really good relationships with the staff in their district offices. You know, I tell people to be persistent and follow up, you know, but don't get past. I mean, you don't want to email the staff person, you know, 3 times a week. But, you know, we have good things this year, and I always tell them to share things, you know, or invite them to things. And we always try to get people to invite a legislator to a dialysis center, and believe it or not, they come. You know, every August there's a big effort, primarily organized by the American Nephrology Nurses Association, but they involve all of the kidney community in it. They organize getting members of Congress or their staff to visit a dialysis center in August when they're back home during their long August recess. And invariably, they probably get 30 to 40 visits every August. We encourage people to go to those. We try to get elected officials, members of Congress to some of our kidney walks as an honorary chair. You know, that's a good way to you know, just to kind of get outreach and, you know, involve. I always try to tell people, you know, share good news. You know, if you've developed a relationship, you know, at least where they know you, if you see something in your local press about a kidney care donation, send it on. You know, so that they're seeing that there's, you know, good things, and, you know, look at this, FYI, or these are the kind of things that work, instead of always hearing from constituents when there's a need. So this will kind of walk you through. I think you're sort of what you were alluding to. What you can expect in meetings, and it's not very involved, but go ahead. That has a lot with the elected officials. They want to chit chat about everything, except, you know, why you're really there. And it can be kind of, well, we'll come back to it, because the tricky part is anything other than the reason you're in the talking about. Well, last year I did some meetings with Alonzo Mourning, and he was there to talk in large part about the immunosuppressive drugs. And he knows the issue, and you know, he's the first one to say, look, I don't need this help. You know, I've got a great pension benefits and health benefits through the NBA. You know, the guy's got $1 million, but he said, you know, I'm here for other people. You know, every time we met with a member of Congress, all of course they want to talk about was basketball, right? And, you know, he was cordial, but he did a really, really good job about bringing it back to the reason. You know, so I didn't have to say it, or the other you know, lobbyist people that were with him. I mean, Alonzo was really good about, you know, letting him do the chit chat for a few minutes, but then saying, well, you know, what I'm really here to talk about is, etc. So this is something, you know, where obviously you don't have long if you're a meeting. I did some meetings with a group called the Alliance for FDA, which is a group that we're a member of to help increase funding for the Food and Drug Administration. And I think, you know, 2 of our 5 meetings on this incredibly hectic day on Capitol Hill were standing in the hallway. You know, but you just have to deal with it and be ready for it. So the skater is somebody who, you know, they'll engage you in the small talk and be cordial, but they're not really, you know, they're not really addressing the issue that you're there to talk about. So I think that's a case too where you have to help, you know, bring it around and bring it back. Stone face. That's just somebody who kind of sits there, and I've had that happen on a number of occasions, and we've had patient advocates with us where it's happened, and it's quite challenging. And then the person who's overboard is, you know, they act like they're fully enamored with you, and you can't really, you know, tell, you know, are they with me, or like you were saying, you know, are they coached to, as the agree to constituent, well, we'll do about it, you know, everything you can. And, you know, a lot of times we hear, well, I think my boss would be okay with this bill. Well, that doesn't mean they're going to co-sponsor it, or that doesn't mean they're going to help push it. You know, be okay with it can simply mean, well, we wouldn't oppose it. And then this one I always like, actually. I've had it happen, and it's usually somebody who, usually it's somebody I think who knows what they're talking about. You know, they'll grill you on it, and I actually had it happen with a committee staff member on the Living Donor Assistance Program. You know, for about 15 minutes, she just beat us up about, well, if somebody wants to donate to a family member, they're going to do it regardless if there's a financial problem or not. Nobody's going to do it just, because the money's there, and if they really want to do it, the money's not going to make a difference, blah, 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 blah. And we said that, in our experience, there are people who are apprehensive about it because, because of financial hardship, especially if their out-of-pocket expenses are significant. We have an advocate in Florida who told me he documented everything, that all the expenses he had going from Florida to New York City, 3, 4, 5 times in order to donate a kidney to his brother. He said it cost him a little bit over $5,000. He said, I could afford it, but I kept those, I kept that so I could tell people what it entailed. And after about 15 or 20 minutes of this, when we made our argument about, and I said, it's really, it may not increase living donation hardly at all, but it certainly levels the playing field and it lets people of the lower socioeconomic backgrounds do it. She said, my chairman wouldn't have a problem with this. But she wanted to grill us on it. And so if you go back to those, I don't know how many of these you can remember, but which one of these do you think would be the most challenging or
Stone face. Keep you busy and you're
that's
moving
the
over.
worst. The stone face is the worst because they'll just
What to do.
because you can't read their response at all. And I did a meeting a few years ago. We had a gentleman about 65 years old from Tennessee. His wife was a dialysis patient. He and I were doing meetings one-on-one, and about our 5th one, we came out and we're walking down the hall and he goes, well, that was our stone face, and he said, I'm glad that wasn't our first meeting, and that's absolutely right. I mean, if you go in, and here I am trying to tell you that this is easy to do, and now I'm trying to do that you have to be ready to expect anything. But it's the worst, because I'd rather have somebody say no. And we've had that happen. We have that. I mean, sometimes you get staff people, they're speaking for their boss, or sometimes they're just speaking. I think you're just trying to create problems. Where they'll say, I appreciate somebody saying, I don't think my boss can support this. I'd rather have to be candid so you know where they stand. But that is, to me, that's the worst, because you don't know. You didn't get any feedback and you feel like you just wasted your time. You're not really sure where to go.
That in general has been Denmark's biggest challenge. You have somebody for you, great. Against you, good. You got energy to argue again.
Yeah.
Convince them. But the one in the middle that just, that sits there,
Right.
and there's no wind in that sail.
No.
You can't tack, you can't go forward.
I think the only thing you can do after that is maybe just follow up, and then maybe follow up just by email or whatever. You might get at least some feedback. I think I just have a couple more. I guess we didn't have it. So yeah, that's not.
That's ideal, but probably unrealistic.
Pardon me?
There aren't really many.
Yeah. Well, I mean, there's some. I mean, you get people that where you can tell that their boss is really interested in this year. They want to get involved in it. So it can be one or the other. But I mean, I think in most cases when you're meeting with an office, you're building a relationship. I mean, it takes a while to get them engaged in something. So these are 2 things you can do pretty easily. There's a organ and tissue donation caucus, which I can send you a roster if you like. It doesn't have very many members. I think it's got about like 15 or 20. But there's dozens and dozens of congressional caucuses, and it's usually. Clearly, if the chairman of the caucus is somebody who's got a strong interest in the issue, which is good. Sometimes it's a national thing, or doesn't have a geographic basis or home-based interest, which of course is the case indeed. I mean, other times there are. It might be. I mean, believe it or not, there's like a congressional. I think it's thoroughbred caucus or horse caucus you know, and the people that are in it are from Florida and Kentucky where they do horse breeding. So there's, you know, they have a program like this. But the organ and tissue donation caucus is something that Kidney Foundation is not very active in. A lot of the other groups are more active, like AOPO and NATCO and things like that. But Costa is from California, and Ross Latina is from Florida. So those are the two co-chairs. But the one that we're closely involved in is the Congressional Kidney Caucus. There's about 55 or 56 members in it now. And Jim McDermott from Seattle, Washington is one of the co-chairs. And then interestingly, Tom Marino is a freshman from Scranton, Pennsylvania area. And the previous co-chair was Mark Kirk from Illinois, and Kirk was very interested in being in the caucus and, you know, wanted to do something. He approached us about 8 years ago, and he wasn't on any health committees. He said, but I want to do some health issues because my predecessor was very involved in health, and so we were talking about starting this caucus, so he was willing to do it. Now, Kirk was elected to the Senate last year, and he's expressed interest in trying to add some Senate members to this as well. Right now, both of these caucuses are House only. So we're looking for another Republican co-chair. McDermott's a Democrat. And Marino came to our World Kidney Day reception. We do a congressional reception every year for World Kidney Day, and we involve other members of the community, the kidney community, and, you know, invite everybody, etc. And he showed up and introduced himself, and somebody was speaking. I think it was probably McDermott. And I said, you know, it's just a quick informal program. I said, you can say a few words here in a few minutes. He goes, I don't really want to say anything. And I said, well, you know, if you want. He goes, well, I'm a kidney cancer survivor. And I was like, well, you really need to say something. You know, so he starts telling me a little bit about it, and he wasn't hesitating to talk about it. He got up and in front of these, you know, 60 or 70 or 80 people, he did the same story. So obviously within about 5 minutes, we started asking the staff if he'd consider being the chair, and he agreed to do it. So we're really excited about it because here's an example that we got somebody, you know, he's a 2-time kidney cancer survivor. I don't know, you know, I don't recall the specifics of it, you know, when he was first diagnosed or anything. And, you know, he'll be able to share a story with his colleagues, and I think the good thing is, I think he'll be able to encourage a lot of his fellow freshmen to sign up for the caucus, because I think a lot of newcomers are going to be a little apprehensive. There's nothing involved in being on the caucus. There's no staff commitment. I mean, the only people, staff-wise, who do any work on the caucuses are the staff of the co-chairs. You know, and the kidney caucus, for example, there's McDermott and Marino are co-chairs, and there's 2 vice chairs, Jesse Jackson Jr. and another doctor, John Fleming from Louisiana. We got him to agree to be the Republican vice chair this year. Other than, you know, 1 staff person in each of their offices, there's no commitment, there's no cost, there's no time commitment, so it's easy for a member to join a caucus, and it basically, you know, helps them learn more about the issues, but they can also help us because we know who's involved and who's interested in those common issues. Kidney Caucus had their first staff briefing of the year on Tuesday. I wasn't present because I was out of town, but they did a presentation on home dialysis therapies with 2 nephrologists and 2 kidney patients. I think that's it. So, questions, or you want to have a discussion?
Question.
Yes.
How involved, or is he involved, Bob Casey in Pennsylvania?
He's very interested in donation, as you can imagine. And in fact, when I met with Senator Kirk's staff about a week ago, and, you know, she said, you can help us think of a Democrat to make the kidney caucus bicameral, and that was one of the options I suggested. You know, he doesn't have a specific interest in kidney, but certainly in yeah. His father had a heart. Okay, I couldn't remember what. I knew it wasn't kidney, but yeah. So we had a good meeting with him. Then the American Society of Transplant Surgeons set up, not with him, but with his chief of staff and his legislative council about a year ago on the immunosuppressant bill. I mean, it was a really good meeting, and somebody from ASTS, I believe it was a secretary, is from, I think she was from Harrisburg, somewhere in Pennsylvania. So we went in with the ASTS Washington representative, myself, and then this woman. Easily a 45-minute meeting, but Casey's definitely very interested in these things. So, and he signed on to the immunosuppressive bill, a few weeks after the meeting and whatnot. He's somebody that I suggested they put on their short list for, for that. Yes, sir.
Yeah, I just want to say one thing that came up at one of our board meetings on the immune suppressant bill. I just figured everybody in Trio would support it, and lo and behold, we get this. It's only for kidneys.
Yeah, well, it's a good point. We know that. It's only for kidneys because Medicare only covers non-kidneys if you're age or disabled, right? Well, if you're age or disabled, you already have lifetime coverage. That was a change that Congress made over 10 years ago, in 2000. So it used to be, if you're 67 years old and you had a kidney transplant or any organ transplant, you only got coverage for 3 years, even though all your other Medicare continued indefinitely, lifetime. Congress changed that. So right now, anybody who is either 65 years old or on Medicare because they're receiving SSDI, they have the lifetime coverage. The reason the immunosuppressive bill is kidney only is because kidney recipients qualify for Medicare regardless of their age. Anything else?
And most of that seems to be because it's a money saving. Keeps it
Well,
going
yeah,
down.
I mean, that's a big argument. That's ASTS, the transplant surgeons and the transplant physicians, American Society of Transplantation, they really make that argument a lot.
Oh, that argument doesn't
You don't think so?
I mean, it's the only one that makes sense today in that environment. You got to
But
show
why
them.
give transplants to other
But the
other
rule,
organ transplants?
the rule today is you don't get any more money. You find out where to save it, then you can use it.
Well, but you know what? But
right?
you know one of the. But actually, when we meet with a member of Congress on that issue, usually we get them to sign on to the bill because they say, well, wait a minute, we're paying for dialysis and we're paying for the transplant, but we don't pay for the drugs. And you get them on the, Now, I'll be honest with you, 9 out of 10 meetings you're meeting with the staff, and the staff person, will say, we'll take a look at this, and, if you keep following up, usually we can get them on. I mean, we had 90-some co-sponsors on the House bill last year, but if you meet with a member, it doesn't take much to convince them, especially when you tell them that the drugs cost Medicare about $15,000 a year, and a dialysis patient costs Medicare about almost $70,000 a year. That's not just for their dialysis, that's all of their Medicare, so it's about a fourth of the cost.
And when we met with some of those representatives, that's exactly the issue. You have to show them mathematically where spending this saves more over here. And if you couldn't substantiate that, and that was the problem, as I recall, the Kidney Foundation had, getting the budget group to validate those numbers so that they were provable numbers as opposed to just claims.
Well, I will say this. I mean, the good thing about immunosuppressive is, we have Democrats and Republicans on both sides, especially in the House of Representatives, that they really want to get it done. I mean, they met together as staffs. I mean, so it's not just a Democratic sponsor who's pushing it or a Republican sponsor or whatever. But the other thing is when I do visits, I tell people, not only do you owe it, I mean, you want to do it for the patient. I said, I think as a social policy, of course, you want to protect all the organs you have since there's an organ shortage. But I also say as a social policy, you want to do it for the living donor and certainly for the donor family. You want to do everything you can to make sure that transplanted organ keeps working. The donor family has made a sacrifice. They have, they have an interest in long-term outcomes as well.
Well, hopefully with the if it go, stands, it doesn't get challenged and overturned, with the healthcare changes and everything.
Yeah.
And eliminating the pre-existing, people can return to work,
Right.
get insurance on their own. They
Yeah.
may not need it, so I guess what I'm saying, I'm just gonna take the devil's advocate position.
Okay.
So we're assuming that if they don't have the coverage, that they automatically will not be able to pay for it, rather than
Right.
assuming that
Right.
a large percentage of them will be able to return to society and work and have their own insurance. And if they don't have a pre-existing exclusion, they can provide their own insurance then
Yeah.
at that point. So, I'm just
Yeah.
gonna bring that
Well,
point up.
I did a presentation on Wednesday to kidney professionals on the healthcare reform bill, and I told them, there's a handful of areas I think where there's universal agreement are the pre-existing conditions and eliminating the lifetime caps and the annual cap. The lifetime and annual caps of benefits. I said even Republicans who are opposed to the broader law, I think everybody agreed that those were things that had to be addressed. Now, it's interesting you talked about the coverage, the pre-existing conditions, but also initially last year we were trying to get the lifetime coverage, and then when the end of the year came up, we knew that wasn't going to be possible. That's when I suggested to Durbin's office, well, what if we do 3 or 4 years coverage until the health insurance exchanges kick in, and that's in 2014, where the people who are uninsured would be able to go to a broad marketplace and basically buy an individual policy at a group rate. And Durbin's office agreed to do that, and we, because they think that once the exchanges are up and running, there won't be a need for immunosuppressive coverage, for a separate bill, that everybody will be able to get it through insurance. Our concern is nobody knows yet what's going to be required in the, there's something called essential health benefits. And Congress literally said the essential health benefits in the insurance exchanges had to be, quote unquote, equal to a typical group insurance plan. Typical employer plan. Well, how do you define a typical employer plan? So, which HHS is working on doing that, but our concern was, the lower tier plans aren't going to have a drug that's $15,000 or $20,000. And Durbin's office thinks it will. So that's when we said, well, let's find out. And they were going to cover it through 2013. We wanted to go beyond that. Well, when we met with them a few weeks ago, now they're agreeing to do it through 2015. So that would give 2 years of data after the effective date of the insurance exchanges, where we go back and look and see, is this needed or is it not needed? The other argument we make with it is the way the bill is drafted, Medicare would pay for the drugs after 36 months only if the person didn't have other coverage for it. So if you have group health insurance or Medicaid or VA benefits or anything else, and they cover the immuno drugs, then Medicare wouldn't have to do it. So we kind of look at it as the extension is Medicare would be a payer of last resort, which we think would hold down the cost. Any questions? Do you feel, I don't want you to be intimidated by this. I think that the toughest part really is it just takes forever. We've been working on immunosuppressives. I told you we got the one thing through in 2000, eliminating the restriction for age and disabled. The paired kidney program, like I said, it took 2 years. Jim, you mentioned the donor assistance. Getting it in the law, well, it took a long time to write the law, but getting it into the broader reauthorization of NOTA wasn't a very tough sell, but then you had to wait for the rulemaking and get the funding. So it's just, it's a long process. It's, you just have to be ready that some things might take a year and some things might take, 3, 4, 5 years to get done. But I think the great opportunity for TRIO is the transplant community does have common concerns, and they do work together very, very well because, their issues are the same.
It's obviously an issue which, when people are exposed to the stories that are in this room, they're moved by it.
Yeah.
Every organization speakers go out to find it to be a moving cause that they can't say no to. wow, that was a great presentation, we've had a long time, give another presentation they've had. So it's a good cause. People like the cause, be able to support it. So it's got that power behind it.
Right, right.
But one
You know,
thing,
you, like I said before, you know your issues and your story better than the people you're talking to.
two things I'd like to offer at the end of the story, if I may. One, when we were part of the kidney fly-in, it was fascinating. It was not go down to the meeting room and go over and talk to somebody. They had professionals come in who had the access to make the arrangements. You get to see the right people, first of all. But secondly, it was like a half day of training of how to be effective. Yeah, you want to tell your whole story. You're not going to get that much time.
Yeah.
What's your message? So they drilled you. I mean, we practiced, and the next morning you came in and they had brunch. Okay, remember yesterday was a hype type thing. What is your message? 30 seconds. 30 seconds. That's your message, whatever it was. And your story's going to support it. You got about 3 minutes to tell your story, and we'll see what happens as far as the question we come back and forth. But your message was key, and there was one thing you wanted to get out of it. Yeah, there was a whole bunch of things. There was one thing to focus on. Otherwise, you lose the impact. It was amazing. It's not a simple, it can be very simple in a complex world. Secondly, I just want to share with you one of the things that TRIO is at the national level with its public policy committee, using a network of local champions in the chapters to funnel that information back to the chapters, hopefully give that champion, somebody who's passionate about public policy, the opportunity then to give actions and take that down to the grassroots level. So a network, if we had the liaison for you to provide, hey Jim, this is what's going on, this is the action plan, this is what we need to do, we want to build the infrastructure to get that out to another audience to synergistically work with NKF.
Yeah. Well, and you know, you're absolutely right about it. You've got, you know, X amount of time to talk about that one issue, but you're one of 8 groups coming through that office that day on health issues alone.
Yep.
So, you know, if you don't do follow-up, you know, it's not worth it, because you're going to forget about your thing a week later. And that's why we always encourage people to, you know, stay in touch, et cetera, et cetera. I mean, I've had this one woman in Texas. She calls me about every 4 to 6 weeks. Wants to know what's going on with the immunosuppressive bill. You know, and she's written, this year alone, she's written every member of the Texas Congressional delegation. You know, she got letters back from 2 of them saying, you know, no bills have been introduced yet, but, you know, so it just takes a lot of groundwork. Now, you made me think of something else. You know, when you said having that strong local person that wants to do the advocacy. You know, the more people you talk to, the more, you know, better likely you're going to find somebody who says, oh, I know so-and-so would take the comment. So-and-so. I mean, that, you know, on the local level, that's going to happen. Yeah. You know, when you talk to people in the home district, they're going to know, somebody's going to know somebody who can get your foot in the door with the right, which only helps. I mean, you know, you can go talk to them on your own, but if you got, you know, somebody with a little bit of muscle backing you up, that'd be.
Troy, on behalf of everybody, thank you very much for your time today.
Thanks for having me.
I will give for you.
Right.
By all means, by all means.
Yes.
Oops, wait a minute.
Oh, I'm sorry.
Did you get what you needed?
Yeah, I think I wanted it with the title and
Do you want one
background
without
too,
the
so
water
we'll
bottle?
have, oh, okay.
No, you want effective.
Is this good?
advocacy.
Yeah.
You want to sing closer?
But I can't get both of you.
All right.
Why don't I hold this? Thank you.